playing it. Perfect.
Okay, perfect. So let me introduce again. I'm Matjaz Vrtovec. I'm coming from Ljubljana, Slovenia. That is a small country in Europe. And I work as an interventional radiologist in two separate clinics, dermatovenerology and angiology clinic in University Clinical Center, Ljubljana. So next slide. Today, we will talk mainly about our experience in our center with this new microwave endovenous technology. A little bit, few words before our results about the physics of the microwave. Next slide. So microwave technology in endovenous therapy is one of the newer technology available. In my center, we use all, so to speak, conventional modalities, from laser to glue therapy and MOCA, radiofrequency. And in the group of newer ones, we use microwave ablation, and we used also steam ablation. HIFU we don't have for the moment. Next slide. So every surgeon, every phlebotomist, interventional radiologist, which is doing endovenous procedure, had his own approach, the best approach to the patient and its anatomy. Of course, when seeking to achieve the optimal result in every patient, every operator should use the modality which knows the best and which will produce the best results in the patient he's doing. Next slide. So what about physics? Microwave frequency is stretching between 1 and 300 gigahertz, and the basic principle is that fastly rotating microwave field causes the dipoles in the tissue, that is water molecules, to rotate very, very fast. And this produces heat. Next slide. So water molecules rotate, that causes friction. Friction causes tissue temperature elevation, and cell death with coagulation necrosis follows. Next slide. If we try to compare the expected effect of microwave technology in the tissue with more conventional radio frequency, there should be a bigger volume of dielectric around the active probe tip when we are talking about technology. Not so microwave technology should not be so dependent about the thermal conductance of the heat as radio frequency is. Here you have microwave technology on the left and the radio frequency displayed on the right side of the screen. Okay, next slide. So if we please click again once or twice. Just click again once or twice, yes. Another time. If we try no, go back. If we try to compare the technologies, microwave with radio frequency, from another field of medicine, and that is oncology, where both of the technologies are in use for a long time, especially for the metastatic ablation, we could expect less peri-procedural pain when we are talking about microwave technology, more predictable ablation zone, and also larger ablation and more predictable ablation volume with microwave compared to radio frequency. Next slide. So the literature about the technology, the microwave technology in endovenous ablation is not vast. Next slide. We started our series, we introduced the microwave technology into the regular clinical use in my center in March 2021. Till now, we did 45 procedures. That was at the time when I prepared the presentation. I counted it this morning. Now we are on the number 60. But for the statistics, we did 45 procedures, and that were 23 men, 23 women, 22 men, from CAP class 2 to 5. 46 were great saphenous veins, 8 small saphenous vein, and 1 thigh extension. Mainly anatomically, the veins were subfascial, but partly we treated also epifascial veins. We can say that the microwave probe is really nicely, greatly visible on ultrasound, and our cohort of patients were controlled with ultrasound and clinically 3, 6, and 12 months procedurally. We observed somehow changing ablative effect. I will tell you a little bit more later on. But we observed no thermal injuries, and comparatively, we observed less pain when we compared the microwave with the conventional laser or radiofrequency technology. Next slide. So our inclusion criteria was a patient were more than 18 years of age. We choose initially patients with not so big saphenofemoral opening. As I said, CAP grade C to 5, normal ambulation was required. Of course, patients with fresh DVT, active cancer, or infected disease were not included in the cohort. Also, patients with serious peripheral arterial disease were not included in our group. Next slide. Hardware. Of course, we are using echo microwave generator in our institution. We also use the soft tip, long blunt tip probe. We were not using the short one, the firm one for the perforators. In our series, only this long probe was used. Next slide. Another click, please. Yes, when you are dealing with the small vein, you can barely see this vein, which was punctured also in the bigger ultrasound picture. You must use, of course, the micropuncture set, but we successfully punctured this thigh extension with the micropuncture set. We then, next slide, changed the introducer to bigger one. Normally we use 7 French introducer sheet to introduce the microwave probe into the vein. Next slide. So when the introducer sheet is in place, then you can put in the microwave soft tip probe. Our experience were quite good with steerability. The probe has quite short active tip, is quite soft, all the length of the probe is quite soft. So you can steer quite successfully also through some more demanding venous anatomy. Next slide. As you can see, also on the ultrasound picture in the back of the photograph, active tip of the probe is really good seen on the ultrasound. Of course, on the probe there is also a little green slider with which you can, so to say, fix the probe when you have the tip in the desired place inside the vein. Next slide. and another click. Again, visibility of the probe tip. Next slide. Of course, before the procedure is done, you must put in the Tumescent anesthesia. All our patients are done in Tumescent anesthesia, not in regional and not in general anesthesia. Of course, patients are lightly sedated with the dormicum orally. At the beginning of our cohort, we used the advised protocol that is 40 watts per 7 seconds per ablative segment, as you can see also down here on the photograph. Next slide. Yes, about the procedure again, of course, as it was said already, when you are ending the procedure, you must be cautious not to burn inside the introducer sheet. So introducer sheet must be withdrawn accordingly. Next slide. In almost every procedure, we not just perform the ablation of the main trunk, but we do the mini phlebectomies, or we combine with some other modality to have as good result as possible. Next slide. So initially, as I said, we used the advised protocol, 40 watts, 7 seconds per segment. But then, because of the initial results, initial controls, we were not very satisfied with this energy delivered and the results. So we changed the protocol used to 50 watts per 7 seconds from January this year. As I said, our patients were controlled 3, 6, and 12 months post-operatively. Till now, we controlled 26 patients. 23 of them were done with 40 watts protocol, and last 3 controlled patients were done with upgraded 50 watts protocol. Of those controlled patients, 11 were women, 15 men, altogether 26 limbs. Next slides. So, first results after 3 months, when we were checking the patients done with the initial 40 watts protocol, were not so great as we expected. We controlled till now 13 patients at least 3 months after the ablation, and 5 of them presented with completely closed vein. In 4, ablated vein was still open but showed no reflux, and in 3 patients, ablated vein remained open and insufficient. And 1 patient had partly opened and still insufficient vein. So first results, as I said, were not encouraging at all. After the next slide, in those first group, after 12 months or 6 or 12 months, were controlled only minority of the patients, altogether 9. And 1 patient from this group, only 1 was controlled after 12 months till now. And when we are looking at the results, a lot, about 60% of ablated veins were still open and still insufficient. The remaining 40% of the ablated veins were successfully closed. That were results from the first group, which was done with 40 watts protocol. And now we are switching to the last part. Next slide, please. So till now, we controlled some patients which were done with higher protocol, higher energy, with 50 watts. And first results in this subgroup of patients is better. In this group of controlled patients, no vein remained open or insufficient. We had 2 treated veins which were partly open and partly insufficient, but majority of controlled patients had a closed vein with no reflex at all. So, next slide. Our preliminary experience lead us to those conclusions. Very nice feature of microwave technology is that flexible probe is really quite flexible. It has short active tip and has a good steerability. Perivenous trauma, we didn't see any, so to mention, important perivenous trauma in our cohort. We should have bigger ablative reach, so bigger diameter veins should not be such a problem compared to other modalities we are using in our institution. We could say till now that the patient experienced less postoperative pain. Of course, the technology as itself has a better safety in the operating room. There is no fear for unwanted trauma of the personnel, so no protective goggles are needed, etc. And another important advantage is that direct contact probe and vessel wall for the good ablative result is not needed with this technology. Next slide. Of course, you need a generator if you start the microwave technology in endovenous therapy. Probe is, of course, not sterilizable and is single use. That is connected with higher price. Of course, this is again thermal method, and the tumescence is, of course, necessary to do the procedure. Next slide. So, microwave technology is thermic method, so to speak, rival to well-established radiofrequency method, but it has, as we see it, quite some aces up into the sleeve. Maybe it will just show up that initially advised energy is really too low to achieve a good ablative result, and probably the exact and the right ablative energy per segment is still to be set. So, next slide. At the beginning, I said we included patients from C2 to C5 in our cohort. At the end, now gaining the experience, we become more brave, and I'm showing here the patient from 14 days ago with active ulcer. We did the ablation through 2 entry points. One entry point you can see here right above the ankle, and the other entry point it's just needle inserted. So with this long probe, we dared to ablate also the perforator, which was long enough. Here you can see the other entry point. I'm sorry, I cannot yet. No, this is the first one. The second one is a little higher. Yes, here, yes. So we introduced also in this second entry point the 7 French introducer and ablated the perforator separately. Next slide. As you see, first picture is 2 or 3 days after the procedure. And the second picture with already closed ulcer, and leg has no edema. This second picture was taken a few days ago. So we were successful also with the C6 patient. Next slide. Okay, that's all of from my side. Here you can see the picture of our capital, Ljubljana, old city, and thank you to be able to share my experience with you.